Good morning, everybody, and welcome to Grand Rounds. Thanks all of you that are here with us today in Wright Auditorium and those of you who are online with us as well. Today I have the pleasure of introducing Dr. Anisa Ibrahim, who's a clinical associate professor of pediatrics and the medical director of the Harborview Pediatric Clinic. Her clinical interests include caring for and outreach to immigrants and refugee populations, specifically those with medical or social complexity. Dr. Ibrahim serves on regional boards focusing on child wellness, health equity, and migration. Nationally, she has served on the Executive Council for the AAP on Immigrant, Child, and Family Health and currently serves on the Society of Refugee Health Provider Research Committee. Dr. Ibrahim is a strong advocate for community-focused work and partnerships. So excited to have her with us today. Welcome, Dr. Ibrahim. Thank you.
Hi everyone, good morning, and thank you everyone for being here. I'm really excited to present about something that is very near and dear to my heart, both refugee health and refugee and immigrant health, but also our specific clinic at Harborview. So really wanting to discuss comprehensive care for medically complex refugees and specifically our clinic's approach to it. I have no disclosures to present today, but if you have a lot of money and would like to help us start a center for migration, you can come talk to me after the event. Our objectives today is to distinguish the immigrant children in your practice, because given the numbers in the United States, we're all caring for immigrant children. Illustrate approaching clinical care for immigrant children, and including best barriers to care and access. Illustrate knowledge to the facilitators of newly arrived children and families, develop and implement a care management plan, and propose opportunities for advocacy. So let's start really with the number of forcibly displaced children. So many of the children who are coming into our care have been forcibly displaced worldwide, and at the end of 2023, there were 117.3 million forcibly displaced people. Note this is the breakdown of the forcibly displaced people. 63.8 million are internally displaced people, so people whose country is no longer safe due to war or conflict, but are not able to safely get out of the country. Then there are 31.6 million refugees under the UNHCR's mandate eligible for resettlement. There are 6.9 million asylum seekers. There are 6 million Palestinian refugees under UNRWA, and those refugees are not eligible for resettlement to the United States under the Refugee Admissions Program, and the UNRWA and the UNHCR are not, do not have the same, essentially, goals or processes. And there are 5.8 million people who are in need of international protection but are not able to get so. And as pediatricians, I think it's really important for us to look at this graph and recognize that the forced displacement significantly affects children. So although children account for only 30% of the world's populations, they account for 40% of all forcibly displaced people, and sometimes that number is as large as 50%. So words matter, and words really, in the way in which we describe a person's migration status, is important not only for communication, but also when it comes to describing an individual, what an individual is essentially eligible for. So the status that a person has dictates what services they will be getting, what kind of resettlement support they'll be getting, screening requirements, and advocacy. So I want to spend a little bit of time getting on the same page about the words that we use to describe migrants. So first is a refugee. I think people commonly see this word, and as somebody who is outside of their country of origin, who are unable or unwilling to return home due to a fear of serious harm, and they file for status outside of the United States. This is something, this is a title that I personally hold. My family was in Somalia until there was political unrest and civil war. We had to leave and seek refuge in Kenya, registered under the UNHCR, and then we were resettled to Seattle after that entire process, and we were welcomed to the US by the IRC, which is the International Rescue Committee, a resettlement agency in Washington. Other people might hold different titles. So there are unaccompanied refugee minors, which I think are really important for pediatricians to know about. They carry, it's essentially the same definition of it as a refugee, but they're traveling without a parent or guardian, and they still file for status outside of the United States. There are special immigrant visa holders. So this is a special designation for specific countries that have worked with the United States military. Most recently, these are immigrants from Iraq and Afghanistan, and they qualify for legal permanent residence immediately. There's asylum seekers. So asylum seekers carry the same definition of refugee in that they are people outside of their country of origin, unable or unwilling to return due to fear of serious harm. However, they file for status either at the point of entry or once they are within the United States. And then there is a designation called humanitarian parolee. So this is humanitarian, there is an urgent humanitarian reason or significant public benefit to allowing temporary entry to the United States. And most recently, we saw a lot of Afghan immigrants come under this humanitarian parolee designation with the fall of Kabul and Operations Allies Welcome. And then lastly, there are visa holders. So there are immigrant visa holders and non-immigrant visa holders. So immigrant visa holders are citizens of a foreign country that would like to permanently live in the United States, and then they file for a visa. And there's non-immigrant visa holders who is a citizen of a foreign country that would like to temporarily live in the United States. This is a quote that always sticks with me, and it came from the summary of UNICEF's Uprooted summary that focuses on children. So these children may be refugees, internally displaced, or migrants, but first and foremost, they are children, no matter where they come from, whoever they are, and without exception. I want to talk a little bit about the refugee vetting process because it's a very involved process that many people actually don't know about. So the refugee vetting process, I thought a lot about, whether or not to keep that picture. It shows people with bombs and airplanes flying under. So although it's difficult to look at, most refugees are escaping just unimaginable circumstances. And once they are able to do that, most refugees must register with UNHCR, United States High Commission for Refugees. And they essentially undergo an in-depth assessment and a background check, and only the most vulnerable or those who are considered not a security risk are referred to RSC. So the RSC is the Resettlement Support Center, and that is funded by the United States. So the United States RSC does pre-screening for all refugees, and they create case files that will then be considered in this next stage. So in this next stage, as you see, there are multiple U.S. security agencies that screen that refugee candidate and conduct biographical security checks, interagency checks. And this can take several years, and there's really minimal insight into what's going on and how long it's going to take. After that, if they've passed that, they move on to stage 4, in which they are essentially referred to USCIS, the U.S. Citizenship and Immigration Services, where where special trained officers with the Department of Homeland Security conduct interviews and collect fingerprints. And then they go to stage 5, which is another meticulous security vetting and also medical screening. And at this point, medical screening is conducted by IOM, International Organization for Migration panel physicians, with the CDC writing all of the public health guidance on the screening. And then after that, the last stage, applicants are referred to attend cultural orientation, and resettlement location is chosen prior to them arriving. Families might be relocated if they have U.S. ties, but otherwise their location for resettlement is chosen and assigned by the 9 national resettlement agencies in Washington, D.C. For example, when my family was coming here, the IRC chose Seattle as a resettlement location, and we had no other insight into what Seattle was. It was where IRC chose, and we had no ties here. And most refugees might have similar circumstances. So now let's take a little bit of a deeper dive into the medical screening that occurs. So many people undergo in-depth medical screening. And as you can see here, under the refugees and SIV column, that's the overseas medical screening process that happens. So they undergo, starting about 3 to 6 months prior to departure, they undergo several rounds of medical examination, vaccinations, as well as presumptive treatments for things such as soy-voiced helminths and malaria. They continue to undergo medical vetting up until the time of departure, doing a pre-departure medical screening, and then the time of embarkment, they get a final pre-embarkment check prior to getting on a flight to the United States. So there's a lot of medical screening that happens. All of this information is forwarded to the resettlement agencies, and then once they arrive here, we'll talk about how they undergo domestic screening. On the other side there, as you see, asylees, because they are seeking asylum at a point of entry or while they're within the United States, they don't undergo this pre-medical screening, but do get domestic screening and treatment, and it's also recommended. Humanitarian parolees, there are USCIS requirements by attestation, and they get TB testing, and they must have immunity or be vaccinated for measles, polio, and COVID. And then immigrant visa holders undergo a overseas medical examination and must show proof of vaccination prior to coming to the United States. Now I want to zoom in a little bit on Harborview, the pediatrics clinic, where a lot of this work for the RHPP program is done. So the hospital, our clinic is a hospital-based full spectrum primary care clinic with a focus on providing care to a mission population. The building itself is county owned, and it's operated and governed by the University of UW Medicine. So the Harborview mission, we operate really in the center of this Venn diagram where most of our families are coming from low income, or they prefer to speak low income backgrounds, or they prefer to speak a language other than English. They come from, they might have high medical risk for any of those reasons listed there, and they might have social vulnerability. And I don't really like to use that word, but they are essentially coming from historically marginalized populations and have been made vulnerable for the systems that are really not built to support their needs. And we have recent immigrant and refugee families, people who have significant trauma history, homeless youth, foster children, teen parents, parental mental health concerns, and even child mental health concerns. So in addition to the wonderful faculty who many of you guys know who are deployed to Harborview, we have a clinical staff. And I just wanted to give you guys the breakdown. And it's notable that many of our clinical staff that support some of our programs are grant funded. So we have a full-time social worker and another 0.3 grant funded position specifically to support people who have arrived to the country from Afghanistan or have been survivors of combat. We have 2 primary clinic nurses. We have 2 refugee health promotion nurses, one of which is here today, so we're really grateful for. A patient care coordinator, a patient navigator, 2 dietitians, which share 1 FTE, 2 family navigators, and an early relational specialist that focus on early developmental screening and early relational health. We have a total of 3 medical assistants and a behavioral health specialist and a psychiatrist who's there half day a week. There are several programs at Harborview that really bolster and improve our partnerships with families, and one of them is the language support and cultural mediation that we have. So in addition to interpreters, we have a program called the Community House Calls or Cultural Case Mediators program, and what their job, and we have them for several of our language groups that we see in large volumes. And in addition to interpretation, cultural case mediators provide navigation, so systems navigation. They provide care management, they do advocacy, and they do education for the family on an ongoing basis. Many of our cultural case mediators will, although they're based at Harborview, if one of our patients is admitted, especially if they're really new to the country, will come to Seattle Children's, we'll go to their home, we'll deliver medications, and really partner with them in a way that helps them, one, settle in, and also learn the system, providing culturally and language congruent care. We partner a lot with the Medical Legal Partnership, and although the Medical Legal Partnership does not directly do immigration, we have really learned a lot from them and received their help in advocating for children who need help with housing rights and specifically educational rights for children who have developmental delay and recently arrived. So now switching gears a little bit, let's talk a little bit about the Refugee Health Promotion Program, or RHPP as we call it. So the RHPP at the Pediatrics Clinic, this is our mission. We aim to promote the health and well-being of children in complex health care, children with complex health care needs through care provision, public health screening, care coordination across sectors, education, and advocacy in order to really help these children and families thrive. So what is it? This slide is courtesy of Diane Reichert, who's our lead nurse. And RHPP is really our state's unique approach to supporting clients and patients and families with higher medical needs. We take a multidisciplinary approach, and our partners include all 5 area resettlement agencies, the Harborview Medical Center, which there's an international medicine clinic that cares for the adults who are medically complex, and then the pediatrics clinic. We partner with DSHS Office of Immigrant and Refugee Affairs, ORIA, the Department of Health, and then HealthPoint. And HealthPoint is a federally qualified healthcare center that cares for all of the newly arrived refugees who are not medically complex. So we have several goals for our within our RHPP program. So we want to welcome families and aid in their adjustment to their new healthcare system while caring for their children. We help facilitate and collaboration with specialty services and therapies. We'll see a little bit later how medically complex the children in our care are. We want to ensure proper enrollment in school districts with a focus on upholding educational rights. Many of these children might have never had an opportunity to attend school and might have never been had enough resources or support to attend school. And then we partner with resettlement agencies to support newly arrived medically complex children. So while we have our goals, there are certain resettlement agency services and requirements that they must do. So once a resettlement agency accepts a refugee family or an immigrant family, they must help the family do the following, which is applying for DSHS cash and food benefits, applying for WIC. They help them apply for Social Security cards. They apply for Medicaid. It's important to know that every child in Washington State, and we're really incredibly lucky to have this, once they step foot on SeaTac Airport, is eligible for Medicaid. And Medicaid will partner with agencies. So we're often seeing these kids very quickly. Just want to, have everyone rest assured if there's a refugee patient that arrives and then comes to Seattle Children's, they are Medicaid eligible. They help the families apply for employment IDs for all family members because refugees are expected to be financially independent within a relatively short time frame. Ensure arrivals get established with primary care, either with us or with HealthPoint. They connect families with ESL and employment services. They enroll the children in school. And all of their services really last for only 90 days. So from the time that they come, they get case management and resettlement agency services for 90 days, after which they are no longer getting support. Many of our children are referred into an intensive case management program after the 90 days, in which they can get more caseworker support only for the medically complex child for a period of about a year. So delving a little bit more into what we do at Harborview. So we are a primary care medical home, and we for the complex medical cases, and we are doing both pre and post-arrival file reviews and triaging arrivals. We help facilitate the care of the complex pediatric patients. We are often providing clinical consultation to resettlement agencies who are receiving a lot of medically complex children but do not have a person that is clinical on their team. And then we assist in ensuring that the very medically complex cases, especially those who have to arrive with a medical transport, are arriving safely. And this is our Harborview Cares for Kids logo. Sometimes we do have Harborview's an adult hospital, so we're often reminding them we also care for kids outside of the clinic. So talking a little bit more about what we do case file review. There is one of our nurses and our physician, Dr. Dawson Hahn, and our nurse, Ryan Deckard, are often doing case review before the patient arrives to the United States. So resettlement agencies will let us know about a referral. We'll say this patient is going to be coming within the next several weeks, and we review that case and provide feedback and document feedback and consultation. Sometimes a resettlement agency might say we are trying to refer this case to Eastern Washington, and given the complexity of the case, we might say this person needs intensive tertiary care, so we actually recommend that they come to Western Washington, at least initially, in order to get the services that they need and the tertiary care that they need. We partner with IOM and the International Organization for Migration and agencies to ensure the safe arrival of these complex cases. We're partnering with resettlement agencies and public health to refer cases after they arrive, because sometimes, especially for pediatric cases, these diagnoses might be missed prior to them coming here. And if they get to public health for refugee screening, or if it's discovered at the FQHC that this child is medically complex, we will still accept that referral even after arrival. We serve as a medical home, and most of these children are being referred, are seen within a week of arrival, sometimes 1 to 2 days after arrival. And then we refer the pediatric patients to specialists and really coordinate their care and transportation as well. And we've been busy. So how many refugees and immigrants come to the United States, or how many refugees come to the United States is actually a presidential determination that happens at the end of September every year before the federal fiscal year starts. And the U.S. This year will be welcoming 100,000 people seeking refuge and 30,000 special immigrant visa holders. And Washington State is in the top 5 resettlement states. And I think that's something to really be proud of. As you see on the graph here, since the inception, kind of around 2018, we've been getting incrementally busier with a dip in 2020, of course, during the pandemic. And From about October 2023 to the end of August 2024, we've had 107 medically complex cases that we've welcomed into the clinic. I think a lot of this work and our capacity was significantly increased by welcoming Diane Reichert, our wonderful RHPP nurse that started in June 2022, and then welcoming Lisa, who is our second RHPP nurse in November 2023, and we could not do the work that we do without them. Some months we have slow number of referrals, and some other months we are getting 10 to 13 referrals into the clinic of very medically complex children. So our approach to care is what I've listed here. Because we serve both as a medical home and often a feeding home for newly arrived patients. Our team really focuses on team collaboration and communication with multiple disciplines. I think it's really important to honor the family, the parents' care of their child and their experience up until they get here. And as we partner with them in care and start making our recommendations, it's important to honor how much they've done for their child with the limited amount of resources that they had. I often say if a family has cared for and provided beautiful care with limited resources for their family under hardship in Kabul, they are going to survive Kent, Washington. And it's really up to us to ensure that we're giving them the support that they need, honor their wishes, and then partner with them in a way that feels respectful while providing our medical guidance. We address systems barriers, really identifying what is difficult in our system, which is often a lot, and then try to address that. And we do this through various examples, such as making appointments for families who are having a difficult time, or for all of our families when they start obtaining appointments for referrals, being in communication with case managers, ordering durable medical equipment, and communicating with schools. And our work really begins when the children are overseas, and it continues with them in our clinic's care. So now I just wanted to provide just a couple of case examples for how medically complex the children who are coming into our care are. And then often this is a statement that we're receiving overseas. We might receive a little bit more information. We might receive a specialist report, but many times this is the statement of complexity that we're receiving. So case one, a 5-year-old girl with cerebral palsy, global developmental delay, a seizure disorder, and severe malnutrition. We might get a couple of vital signs and anthropometric data and which medications that she's on, but this is the level of detail that we're often getting. And if there is more information, then our partners will send it to us. Case two is a 10-year-old male with cerebral palsy, severe intellectual delay, severe anemia requiring multiple transfusions, moderate persistent asthma, and a history of multiple admissions for pneumonia. And then case three is a 3-year-old male with unrepaired congenital heart disease, malnutrition, speech delay, and gross motor delay, and families concerned that he's not independently walking yet. So that's just a small sample of some of the families that we've recently welcomed. And then this is our process. So there are several referral flows into our clinic, as I spoke about later, but the most common referral flow is while the child is overseas with imminent travel. They will get referred into our clinic and will be triaged before arrival. They have a first interdisciplinary team visit. They'll have multiple referrals and therapies, and then follow up, and we will do complex care follow-up as well as routine preventative care. The other workflows include the green on the bottom, which is a referral and triage through a federal qualified health center and HealthPoint. HealthPoint recognizes that this child has significant medical complexity, and they'll be referred into our clinic and will be seen. And then the last one is all refugees, unless they get it at a different clinic, are getting refugee health screening, typically within 90 days of arrival by Public Health Seattle and King County Refugee Screening Clinic. And there, one of the nurses or providers might recognize that there's a medical problem and refer to us. So as I mentioned, our work really starts before arrival, and there is both a nurse and a physician who are working on this prior to the arrival. So often, like I said, Diane will review a referral and look at scheduling the patient and really determine the timeline in which they need to be scheduled. The most complex cases are discussed with the RHPP lead physician, Dr. Dawson Hahn. And then we are placing holds in anticipation of the patient arriving, and this is really important because most of these families we're having to see within a week of arrival. And as you can imagine, a primary care clinic slots will get taken up if we're not preemptively putting them on hold. And for that visit, it's a visit with a physician or a provider, a dietitian, social work, and the RHPP nurse. And then we're often communicating with the resettlement agency, informing them of appointment times, and then having them arrange transportation for that initial visit. Then at arrival, there is if the child has significant medical issues, there's a warm handoff for a medical escort. So a child overseas, if they're determined are significantly medically complex, will arrive with a medical escort. That will accompany the family from where they are leaving all the way to SeaTac Airport. And we have a physician, most of this work Dr. Doxson Han does, which I'm really grateful for, who accepts that phone call for a warm handoff once the patient has arrived in SeaTac. At that point, we really determine, can this child wait until the appointment time that we've held for them? Do they need to be moved up, or do they need to go straight to Seattle Children's Hospital for the emergency department? The day after arrival, often we have a RHPP nurse calling and checking in with the family, really seeing if they have urgent needs, and then completing what we call a migration history. And then we confirm the appointment time with the family and communicate with the resettlement agencies. I think this is a migration history. It was initially described by Dr. Kronig and Dr. Doxson Han in their paper, Health Considerations for Immigrant Children, and then we have also written about it most recently in the paper in this QR code, authored by myself, Dr. Linton, and Dr. Doxson Han. The migration history really helps you get a history around before the child's medical complexity around the family and around the child and the family's experience, and really helps you risk stratify. So we're often asking location of birth. Many families might have protracted migration, and many children might actually be born while the family is waiting and seeking refuge and waiting to be resettled. The number of years of the United States, if they are not coming in through our usual pathway. And if you see this child in a clinic and they tell you that they're a refugee, it's important to know how many years they've been here, what nationality they are, and not expecting it to match what a person identifies as and what is written sometimes may not match. Their preferred language is really, really important. Some families might speak 5 languages, and there's a language that they prefer to speak socially, and then there's a language that they prefer to get medical information in. And the example that I give is often, my aunt is a Somali woman, but spent all of her life in Italy. So when she came here, she was often offered a Somali interpreter, and her language of preference was Italian. So as you can imagine, what she looked like was not congruent with the language that they thought, so she was often having to ask for a different interpreter. So I think it's really important to ask families. Another thing along with languages, I ask for literacy, right? So some families might speak 5 languages and might not read or write in any of them. Or they might prefer to speak one language but are stronger in reading and writing in another language. So it's best to ask this as the first visit, because it's just you getting to know the family, rather than stopping at 5 visits later to ask, because then often families say, what did I do to make you feel like you needed to ask me this question at this point? We talk about immigration status, and that's really which designation this child falls into, whether they're a refugee, an asylee, or an immigrant. The migration path to the United States is important. Many of our refugees are having to leave their country and sometimes have to go through multiple countries prior to getting to a country in which they can register with the UNHCR. And if you're a child traveling through that, or if there are parents traveling through that, it'd be important to know, and it'll help us risk stratify. The access to healthcare. Some families have had good access to healthcare, and some families have had zero access to healthcare. And educational access that the children have had, and then family, really which family that they were able to come with and which family that they left behind, which is often on many people's minds. So I wanted to give you guys a case example. So this is a little girl, an example of a little girl that would be in our care. So Rayan, she's an 8-year-old girl with cerebral palsy, seizures, global developmental delay, moderate malnutrition, and frequent respiratory infections. The family has had limited access to physicians and no access to therapies. She has not had an opportunity to attend school. So what is happening for a patient like Rayan is that we find out about her, we triage her, and set aside appointments for her to come into our care. So Rayan came with a medical escort. She landed at SeaTac Airport at around 8 p.m. and around 9:30 is when we got the call from the medical escort saying that she did well in the flight. She did not have any increase in seizures. However, the medical escort did find that he had to closely monitor when she was being fed, because he was just afraid and she would cough sometimes. The next day, our nurse did a check-in, and parents reported that she had baseline health, and they did not have any concerns at that moment. Of course, they were exhausted after going through such a long trip. During that check-in call, family let them know that there are 2 additional siblings at home, a 4-year-old who is healthy and a 2-year-old that is really not speaking yet, and the parents are concerned about speech delay. And then mom has a significant trauma history. And then we confirmed the appointment and made a plan with the caseworker for the family to have received transportation to our initial clinic visit. So this is what happens in our first initial visit. It's a very involved visit, and we really work as a team to ensure that we do as much as we can to provide an efficient and a good experience despite all of the things that we have to do. We do prepare the family for a longer visit and that they'll be meeting multiple teammates. So initially, the medical provider, whoever it is that day, will will do a medical history and diagnosis. They'll confirm the migration history, as depending on what time we see, parents might offer more information. We address current concerns. We conduct what we call refugee health screening that's required by the state. We review and update vaccines if we're able to in that visit, and then we do all of the referrals and durable medical equipment. The family also meets with a dietitian. We are often trying to be in the room at the same time, so the family sees us as a team and is able to ask questions. The dietitian does a nutritional assessment, looks at supplemental nutrition and gives samples if we have them in the clinic that day. We establish Harborview as a feeding home and then provide some family education. They meet with a social worker that does an introduction and intake, and then they meet with our RHPP nurse, who they've probably already heard from on the phone, or are meeting our second RHPP nurse in the clinic. That does an introduction, provides details about how to contact both the RHPP nurse and the clinic, get releases of information signed if we need them, and then they help the patient really navigate the clinic, and that we have to send many of these families to the lab right afterwards, to the pharmacy to pick up medications, and then sometimes to radiology. So refugee health screening, as I talked about, involves, and mandated by the state, involves history and physical, complete vital signs with anthropometric measurements, nutrition and growth assessments, immunizations, labs, including tuberculosis, viral hepatitis, HIV, lead. Doing presumptive treatment if they have not already received presumptive treatment for intestinal parasites and malaria, and then doing an emotional wellness screening, look at a child's mental health. This domestic screening, it typically needs to occur within the first 90 days for non-medically complex children, but for medically complex children who are wondering, who we are welcoming into our clinic, we have an agreement with the state that we will do this screening and that we will send all of the results for the screening. This QR code is to CareRef, and CareRef is a wonderful resource it's essentially a tool that guides clinicians to conducting a routine post-arrival medical screening of newly arrived U.S. Refugees, and it really gives you by detail what to look for in the exam, which labs to get, risk stratification, and it's really, really great. So going back to Rayan, that first clinical encounter, after confirming medical surgical history, migration history, we found out that she was currently on one seizure medication, and mom doesn't know exactly at what age she was when it was prescribed, and she does not have any rescue medication and has not been trained to provide any rescue medication. Mom's main concern that day was that Rayan started to feel warm last night and was coughing a lot more overnight. Her seizure frequency has also increased significantly since arrival, and she's been feeding less often but has normal urine output. So in addition to doing our typical things, that day we had to treat her for aspiration pneumonia and obtain chest x-ray and follow up with the family. Rayan had in light of current illness, we deferred some things, such as discussing vaccines and vaccine catch-up. Rayan had a total of 8 external referrals, all of these to Seattle Children's, and 2 internal referrals. Right, and this is very typical. Most of our new refugee visits generate 6 to 8 referrals. We had to do a neurology doc-to-doc conversation in which I said her seizure frequency has increased. She's been on one medication. The parents have not been trained in giving seizure rescue, and the provider provided some guidance on increasing the medication so it would be weight adjusted. The internal referrals at Harborview are nutrition, and they were also referred to our cultural case mediation program. And at this visit, we ordered supplies such as formula and diapers, and then put in referrals for things such as an evaluation for a wheelchair and a feeding chair. So post-visit, there are a lot of things that happen. First, we determine before they leave the clinic, the follow-up. So routinely, children will follow up within 2 to 4 weeks, and we schedule the patient prior so that the case manager is also aware. Some patients, such as Rayan, will require close follow-up. So we're seeing the patient in 2 days or up to a week. We often provide a letter documenting diagnoses and medications to the family, especially if their child is acutely ill. And this is a huge help when you have a family that's just arrived, might have been here for a few days, and something might happen to their child and they need to call EMS or come to their emergency department. It has a document that documents everything that we know and that we're serving as a primary care home. So if the 911 shows up and the EMS shows up, they can just hand them this paper because often they don't have interpreters in this emergency setting. And then we communicate plans to the case manager and the resettlement agency. Internally, our patient care coordinator gets on the phone and calls and makes appointments for every single one of those appointments. And as you can imagine, it's 8 different clinics, 8 different timelines. Once we get all of these appointments, they send it to the nurse and the PCP, and the nurse really jumps in and looks at these appointments with a clinical lens. If we have a child who is having these kinds of seizures and the first neurology appointment is 2 months from now, then she's often getting on the phone and saying, given the clinical urgency, or here's the new information that we have, can we get an appointment that's sooner? And then we communicate all of these specialty appointments to the resettlement agency and the family. We often have follow-up visits based on the medical need, and we follow up on medical issues. We often are following up on referrals and saying, were these scheduled? Are there any barriers to getting to these appointments? We check in on DME, whether it was delivered or not. We do vaccine catch-up. We do a lot of school enrollment and IEPs. We've had a lot of learning that has happened from children not getting evaluated in an adequate amount of time due to several reasons. Sometimes it's people thinking that they need more time to adjust and not getting a IEP evaluation, or saying, it might be a language issue. So we're really advocating for children's rights and educational rights, and saying that they, by law, should be getting an IEP evaluation. And we sign this form and have the parents deliver the form to the school. Once this form is delivered to the school, in our work with MLP, we've learned that the school then has 30 days to get this evaluation set up. So that timeline really starts, and this form has been really helpful in getting this timeline started. And then I think SSI and DDA, these benefits are the most important financial and social supports for families, but they're often delayed. So we're really trying to do a lot of things to help with that. So going back to Rayan, as you see, this is a typical timeline for one of our kids. So we met Rayan on September 30th when we received that initial referral, and our nurse triaged that this patient was going to come in with a medical escort. On October 8th, Rayan arrived with a medical escort. On October 9th, our nurse called to check in with Rayan and remind the family of the appointment on October 10th. October 10th was our initial visit. Rayan was acutely ill. We did all of the things that I had mentioned. And on the following day, our nurse called to check in on Rayan because it was a Friday and we were going into a weekend. So just making sure the family feels prepared and the caseworker feels prepared and supported. We had a follow-up appointment on October 17th at Harborview. Shortly thereafter, due to her increased seizures, she had an urgent neurology visit on October 23rd. On October 24th, the family called us, and they essentially were worried because when they went to the pharmacy did not give them the medication. They said that they did not have it, so therefore Rayan had not started this medication. Our nurse then called neurology, called the pharmacy, figured out which pharmacy would have this medication, and then had neurology change the prescription location. On October 30th, there was a family call because the family is saying they moved from temporary housing to permanent housing. So then we had to change all of the DME and ensure that everyone had the correct address for the family. And then we had another follow-up visit on November 13th. So this is just really to show that we have a lot of contact with the family, especially in these first weeks, and we're doing a lot of work behind the scenes to ensure proper delivery of care. And then families often contact us with questions, even if the questions originate from specialty visits. So that communication from primary care home to specialist is really, really important for us. And what helps us manage the care of the patients optimally is a dedicated team of our RN case managers, but also frequent and in-depth communication with our specialists. I cannot stress enough how amazing it has been to really have this care management. And each of our RHPP patients gets active care management as documented by what's going on here. So we're reviewing records, especially after specialty appointments, to ensure that families are not lost to follow up and following up the needs. We complete the refugee health screening and send it to the state so the family does not have to go to the King County public health. We ensure that DME has reached the families. We're connecting the schools. We're arranging for follow-up and for both preventative care and complex care, because these are still children and they need their wellness visits. They need their vaccines and routine visits. We're arranging specialty care appointments. We're communicating with the PCPs. And then once the child is graduating from RHPP, we develop a transition plan both into either if they want to stay with the clinic, but also if they would like to move closer to home. Most of our families are living in South King County, and Harborview is very far away from them. But most families have not taken us up on that offer. So it's just, how to wean them from having the active RHPP case management. And, collaboration and information sharing is really important. Many of the families are often juggling many things. They have to become financially independent, learn English, get a job, be able to pay their rent all within a few months of arrival. And there's multiple points of contact, and varying information can be confusing for them. So the RHPP program was really built in the spirit of collaboration. So we do intentional information sharing. It is really important for us to know who is doing what for the patient, who's going to communicate it back to the family, and what the next steps are. We hold monthly internal RHPP meetings, and we often invite content experts of something that we're struggling with. So we were struggling with educational rights for families. We invited the Medical Legal Partnership to come and teach us about educational rights, and then we were really empowered to have these discussions with the schools, reminding them of what they were required to do by law. And then we discussed cases for shared learning, because sometimes we get a really, really difficult case, and both for moral support, but also for kind of medical support. And then we do a lot of outreach. So our lead nurse meets with our community partners. She meets with specialists, agencies to really help build these connections. So if you'd like to know more about our program, we would love to come and present and liaise with every clinic and every specialty, because we're interfacing with most all of them. However, despite our best efforts, there are of course pain points for both our clinic and the families that we serve. So this statement is something I think I've learned in like 6 or 7 languages now. So many of our families are like, why do you guys not talk to each other? Like, what is going on? And life in a new country is difficult, and they're already having to navigate a complex medical system. So patients are often frustrated when they're like, you sent me here, and I have a dietitian, and then I went to go see another clinic, and they're like, you need a dietitian, and then all of a sudden I have an appointment to meet another dietitian, and that is confusing for me, and it's not helpful for me, especially as I'm trying to juggle everything else. So communication is really, really important. It leads to not communicating leads to duplication of efforts, and we're all working on the same thing at the same time. And often we are really doing a lot of things behind the scenes, but it's all documented in the EMR. So I think really encouraging specialists or anyone who's seeing our patients, even if it's in the ED, to reach out to us directly, review our notes, and then let us know if there's a point of contact that would be best to work with, because we're really happy to create these connections. And hopefully I will stop learning this in more languages, because the patients really, really do struggle. And a lot of us are wondering, because for primary care, I think I'm biased, I am a primary care provider, but I cannot understate the importance of primary care, because even the families are seeing us often, and they're often saying, the neurologist said this, what do you think? The orthopedic doctors said this, how can I get this done? And the more information that we have, the more that we can emphasize the plans of care, move forward the plans of care, and partner with our families. And then other challenges and opportunities, I think you've heard me say several times that navigation is difficult. There is multiple systems that families have to navigate. You saw that there's 8 referrals. All referrals are at Seattle Children's Hospital. It might be Seattle Children's here, or they might be going to Federal Way, and sometimes a combination of both. Then there's the Harborview system, which is the UW medical system. Then they have to go to multiple therapists and providers, and with different numbers to call, different appointment scheduling systems, different faces that they meet. So that navigation is difficult. Communication across multiple entities. Transportation. So many of our families are living in South King County, but they're coming to Harborview because of the program. They're coming to Seattle Children's because of the specialty services that we provide, and they're often relying on HopeLink. So having flexibility with families. I've had many families who are ready to go, got ready 2 hours prior to the appointment, and then HopeLink doesn't come, right? And then when HopeLink doesn't come, then their neurology appointment gets pushed 4 months down the line. And that's really, really hard for families, especially when something that's not under their control. If you remember the graph that I showed you, our care management needs are quickly outgrowing our capacity, and we have two wonderful nurses who are at times managing 80-something active patients in our HPP and all of the care needs that they have. So we're often thinking about what more can we do to ensure that we're not burning out the people that we have, but also thinking about the moral injury that happens, because we are witnessing a lot of human suffering that happens, especially when they're first coming, so caring for each other. And then schools, especially with regards to integration and coordination and addressing educational rights and misconceptions about that they might have for newly arrived families. So in summary, if I were to say just a couple of things, I think the couple important points to note is that refugees are extensively vetted, and they receive medical screening prior to arriving in the United States. All newly arrived families should be receiving refugee health screening within 90 days of arrival. Our medically complex children are getting it far before that. So if there's a patient in your care, if they have not received refugee health screening, you can use CareRef to help you do that. But most often, these medically complex children are coming to us. Harborview serves as the primary care medical home for all newly arrived refugee medical families who are living in our area. And we provide a series of things, including nurse care management and serve as a feeding home. So if you run into a refugee that is in our care, please communicate with us, because we can get a lot done after, or we can even get a lot done partnering with you while the patient is admitted, while they're in your clinic, or if there's any needs after. And the more we know, the more we're able to help move forward the care plan. And then partnerships and communication are really vital to providing excellent care. I just wanted to share this advocacy flower that was created by my dear friend Julie Linton, and we also reference it in that paper, whose QR code I gave you earlier that we co-authored. Advocacy is really fundamental to the work of pediatricians, and we are doing it in many ways, and and it can occur across multiple and intersectional domains. So each pediatrician might, in caring for the children, might be able to do one petal of this flower, and sometimes you might be able to do all. And while a lot of people might think of advocacy just as legislative advocacy or policy advocacy, community engagement, medical education, and high quality care is also advocacy. And doing any part of that really helps better the care that we're able to provide. So I really wanted to acknowledge everyone that it takes to do this program and the care that we provide. So acknowledging first and foremost the families who trust us with the care of their children, and honoring both their journey and their incredible resilience. Suzine Pack-Gorstein, who did the initial work of creating this program many years ago. Our RHPP team leads, including Dr. Dawson Hahn, Diane Reichert, and Lisa O'Neill, who are our nurses. The clinic staff and providers, our partners at DOH and ORIA, our partners at Health Point, Seattle, King County, our partners in the Washington State Resettlement Agencies, all 5 in the region, and then for me personally, my wonderfully supportive family who does have a refugee migration history and who are the reason behind my dedication and success. So this is our Harborview, a part of our Harborview Clinic team during our most recent retreat. This photo editing credit is to Brian Johnson, who actually was wonderfully covering our clinic so that we could have this retreat. So thank you. Yeah,
10 minutes.
I do want to, I know I'm going to get in trouble, but I do want to honor Diane Reichert, who is in the audience today, for the incredible work that she's doing. He's back there. So it's just an incredible advocate for our patients and families. And I'm often telling her, Diane, you have to stop working. please put down the computer. Because she's so dedicated.
Incredible. Yeah, I can tell all of you are doing incredible work. I'll open things up to questions in the room first. And then I see some coming up.
Great presentation, Anissa. Thank you. I learned something new every time I hear you speak.
Thank you.
My question is about, so you mentioned that for insurance and how wonderful it is in our state that, when a kid touches down in SeaTac, they're insured with Medicaid. Can you talk a little bit about what does that look like in other states?
Yeah.
And what does it look like for the insurance for the parents? Like, are they automatically insured? Because it seems like if they have a lot of medical issues and they don't have insurance, that would make
Yeah.
our job more tough
More
to take care of
difficult.
the kid. Yeah.
Yeah, absolutely. So yes, we are incredibly lucky that all of our kids are Medicaid eligible. In other states, that is not the case necessarily. So all refugees do have a period in which they are covered medically. So there's I believe it's an 8-month period in which they are covered. So the parents are getting some level of coverage, but after that 8 months, it's really dependent on the state. So some places like California are expanding Medicaid and are really able to provide care for children. But some states like North Carolina really don't have a lot of options, and they're having to rely on safety net hospitals, et cetera, to be able to provide this care for the children after that refugee resettlement period.
Thank you so much, Anissa, for the incredible work and leadership of this program and for the care that you are providing as a former beloved physician at Harborview. It's just so exciting to hear about all of the great progress you have made with RHPP.
Thank you.
I have 2 questions. One is, how long typically are children in the care of the RHPP program? You mentioned that some are graduating out, and I was wondering kind of what that looks like typically. And then the other question is just related to our EMR. Part of, I think, some of our challenge with the fact that doctors don't communicate with each other, why can't we do better with that?
Yeah.
Is that we are still challenged in the ways that our EMR is connecting, I think, even between Children's and UW. And when we put in referrals to Children's, we're oftentimes getting a fax back that says, we can't read all of your notes. And so I'm just curious how much of that is contributing as you're working through these, and if you have found any workarounds or other things we need to advocate for in getting our systems a little better integrated.
That is good. Okay, remind me of your first question.
Sorry, just RHPP timeline. How
Timeline,
long
yes.
are
Okay,
kids
yeah.
in it?
So let me answer the EMR question since it's a little bit on my mind. So I do think there are issues with just EMR and communication and what needs there are. However, for the most part, I think I have been able to read most all of my subspecialty notes at Children's, really either going through Care Everywhere or just looking under Epic. And if there is not, we're often reaching out and saying, oh, we saw this child saw you, we just, we don't know the follow-up, the care plan, what can we help do? When we do get, when there is a missing communication, unfortunately, it takes manpower, right? So it is often Diane picking up the phone and calling as a nurse if there's a clinical question or need, or Victor, our patient care coordinator, getting on the phone and saying, we need this patient scheduled, how can we do to help? And in some systems, we actually have to advocate because they'll say, oh yeah, you should have, the patient call. We're like, they are not able to call, right? Even if you have an interpreter, it is a very difficult system to navigate. And if we give somebody a phone number and you can get an interpreter, but you have to first know to press number 1, and then after that to press number 2 to get to the clinic nurse, then that patient, you were effectively not providing care in the language that they can understand. So a lot of the workarounds have unfortunately required a human being to be able to do this work. And then for RHPP, I think Diane can definitely answer this question even better than I. Our initial grand plans were for about a year of services. However, this was prior to the pandemic when children were still medically complex but not coming in as sick. Now we're having children who are even more acute, children and families who are even more acutely ill coming in and just needing support for a longer period of time and having to face a lot more barriers. So we are often having them in services for over a year, sometimes 2 years. And then it is a system that has some flexibility. So sometimes if we kind of let a patient say, oh yeah, they've kind of graduated from RHPP and they can be in the general clinic population, if something comes up, then the RHPP nurses will most always jump in to help them. Anything else you'd add, Diane?
No, I think the big thing is that they are eligible for RHP services within 5 years.
Yeah.
So again, people can come and go, and I think
Yeah.
I think, we also just really have learned that the length of time that families need in this resettlement process, it's not an easy process. There's much to learn. So it is an ongoing assistance that we provide in helping them, reminding them. You'll often hear families say, I don't remember that. I didn't hear that. You might think, oh my gosh, I know I spent all this time talking to you about this. But the reality is that they are still adapting, adjusting, learning how to live in the United States, which is very, very difficult.
Yeah. So for a period of 5 years, they can come and go. And if we are finding a newly arrived refugee family that might not have gotten services because, they had a U.S. tie who then, quickly realized, oh gosh, this is outside of my scope, then we're still able to welcome them within that 5-year time period.
Thank you so much. You mentioned a lot of the rigorous screening that happens a lot of times before they even get to this country.
Yeah.
Are there risks for families getting pre-departure screening? Like, is there risk of them being ostracized by their communities or targeted by their governments back home when engaging in the pre-departure screening?
I think there are a couple of things that are kind of stigmatized no matter what. I don't think the all of the screening, because it's required, all of the families are doing it, but I think they are thoughtful and mindful about, if they come from a place that like a TB diagnosis or, is something that's stigmatized. A lot of, similarly to us, the IOM physicians, the panel physicians who are conducting this are uphold a lot of the things that we uphold, really trying to keep the patient privacy and the family. I think it is, the other thing that's important to know is that at any point up until the family gets onto that plane, their departure is not guaranteed. So, they are getting temperature checks the day they're getting on the plane. And if that temperature is high, then that trip gets canceled. So, most families are complying because they are really trying to get resettled and are really depending on us to keep their information private and secure.
Okay. Thank you. Lots of thank yous from our team that is viewing by WebEx. And one question from Donna Deno. Thank you for a fantastic presentation and the work that you are doing. How does your work with refugees inform the care of non-refugee immigrants, whether they are visa holders or not? And which resources, e.g. through grants or special funding, are specific to refugees only?
Right. So a lot, the RHPP grant itself and the nurse care manager in our clinic are specific to people who are, receiving under the Office of Refugee Resettlement. That's where the funding comes from. So it's for refugees, special immigrant visa holders, humanitarian parolees. Outside of that, all of the core things that we do apply to immigrants generally. So the refugee, we do new immigrant screening that essentially mirrors newly arrived refugee health screening when a new immigrant comes into our care. They have access to essentially everyone else in the clinic outside of the two RHPP nurses, and then they are considered either high risk or medically complex, or a newly arrived immigrant that needs extra support. So our primary nurses, we urge our primary nurses to develop a ongoing relationship with the family so that they are able to get as many services as they can. Unfortunately, the two nurses are doing care management for people who are under the Office of Refugee Resettlement. But everything outside of that, we are essentially doing the same for any new immigrant.
Anissa, thanks so much for that wonderful talk.
Thank you.
I was wondering, for the benefit of the folks, for trainees who are listening to you,
Mm-hmm.
I was just curious if, when you were a medical student or a resident, is this the work that you envisioned doing yourself personally, and were there, what helped you to get to this?
Help me
point?
get there. Yeah, no, I think that is that's a great question. I think, when I was a medical student, I think I was like, I want to become a pediatrician, but I knew that I wanted to work in a clinic that was similar to the clinic that I grew up in, I grew up in the Harborview Clinic. My family came as refugees, and the same clinic that I'm a physician now is the same clinic in which I grew up in. So I had a patient population in mind. It wasn't specifically refugee and immigrant work, but as I went through residency, I did the REACH program. I was thinking about global health and the connection, like the global, the local connection. And really thinking about people who've experienced migration, because that's who I encounter a lot. And I think as I settled into my attending job at Harborview, and throughout the 3 years of doing my continuity clinic there, I think it really became clear that this is a patient population that, given my lived experience, I care deeply about, and that we, frankly, don't get enough medical education about, and the statistics show us that 1 in 4 U.S. children are from an immigrant family. Their families have faced migration, and there are a lot of immigrant children who are just not identified in our practices because we might not assume that they are from immigrant families. So it shows that we are all providing this care, and for me it became important to know that we're providing this care well, and that our residents and our trainees are also getting this education.
Thank you. Thank you so much, everybody. I'll end with this comment from Dr. Grant. Incredible work. You, Diane Reichert, Lisa O'Neill, and Dr. Dawson Hahn work tirelessly in all the areas of advocacy. Thank you for transforming care for the families at Harborview and globally. You do it with such humility and center family strengths. Thanks so much for all of your work, everybody, for being here, and we'll see you all next week. Thank you.